Welcome to The Explainer. Today, we're diving into something absolutely wild. We're looking at the human body not just as biology, but as the ultimate high-stakes command center. Deep inside you, right at this very moment, there's a master control board running the show, and that is your endocrine system. It basically relies on these microscopic chemical messengers, hormones, to send critical signals to literally every single cell you have. And you know, when the system hums along perfectly, you don't even notice it's there.
But here's the really massive question we're tackling today. What happens when those delicate internal dials get turned a little too high or a little too low? Like, what actually happens when those microscopic chemical messengers go completely out of control? Well, the resulting chaos can turn the entire body into a full-blown medical emergency zone. Okay, let's dive right into our exact roadmap for decoding this complex system. We're going to cover 1. The body's control room. 2. Pancreas, the sugar manager. 3. Thyroid, the metabolism thermostat. 4. Adrenals and the pituitary. 5. The endocrine toolkit. And finally, 6. Medical traps and secrets.
All right, kicking things off with Section 1, the body's control room, establishing the baseline.
Because, obviously, before we figure out what breaks, we gotta know who's actually in charge. These are the major operators on your endocrine control board. We've got the hypothalamus and the pituitary gland acting as the top executives. Then we have the thyroid, the parathyroid glands, the adrenal glands, the pancreas, and the ovaries or testes. Now, these glands might be physically tiny, but they regulate absolutely everything. We are talking your metabolism, physical growth, our ability to reproduce, that instant fight-or-flight stress response, fluid balance, and blood glucose levels. They are the baseline of human life.
Moving right along to Section 2, pancreas, the sugar manager, or when the fuel gauge breaks.
Now, what's really fascinating here is seeing what happens when the pancreas faces an acute crisis. It brilliantly illustrates this kind of Goldilocks contrast in diabetes management. The pancreas is always trying to keep blood sugar just right. But when it fails, we see two severe extremes. Diabetic ketoacidosis, or DK, is a dramatic crisis that's much more common in type 1 diabetes. On the other hand, hyperosmolar hyperglycemic state, HHS, is the severe crisis we typically see in type 2 diabetes. Both of these basically mean the fuel gauge is entirely broken, but they present uniquely and require totally distinct emergency treatments.
Let's see how this builds in Section 3, thyroid, the metabolism thermostat, turning up the heat.
So the crucial takeaway here is the clinical contrast. Hypothyroidism, which is commonly caused by Hashimoto's disease, makes everything sluggish, right? Patients experience fatigue, weight gain, cold intolerance. The lab panel is going to reveal an elevated high TSH and a low free T4. But then, on the total flip side, you have hyperthyroidism, often caused by Graves' disease. Everything goes into absolute overdrive. Weight loss, heat intolerance, heavy anxiety. Here, the lab panel shows a very low TSH and high T4 or T3. It's just a perfect mirror image of dysfunction.
But what happens when that hyperthyroid dial gets cranked to the absolute max? Well, that causes a medical emergency known as thyroid storm. We're talking high fever, delirium, heart failure. When this happens, experts strictly follow a sequential, life-saving step-by-step treatment protocol. Step 1, a beta blocker to calm the symptoms. 2, PTU to block hormone synthesis. 3, iodine, but critically, you only give this after the PTU. And finally, 4, steroids. The specific order of these steps, it's an absolute matter of life and death.
Actually, speaking of those thyroid medications like PTU and methimazole, I want to drop an exclusive insider secret right here. It's a board pearl that medical experts memorize. If a patient taking these hyperthyroid meds develops a sudden fever or a sore throat, it could indicate agranulocytosis. And that is a severe, incredibly dangerous drop in white blood cells. The immediate response? You stop the medication instantly and get an urgent complete blood count to check for this condition. Seriously, you do not wait around with this one.
Let's go even deeper into the control room now with Section 4, adrenals and the pituitary, stress and master controls.
Here we've got another massive clinical contrast, this time regarding cortisol. Addison disease means dangerously low cortisol. Patients deal with fatigue, weight loss, and their labs will often show hyperkalemia, which is high potassium. Contrast that with Cushing's syndrome. This is way too much cortisol. These patients present with entirely different physical signs, like a moon face, a buffalo hump, easy bruising, and their labs often show hypokalemia, or low potassium. Once again, it's the master dial turned way too low versus way too high.
Now, staying with the adrenal glands for a second.
Imagine you need to identify a highly rare adrenaline-pumping tumor known as a pheochromocytoma. If you only had 3 clues to look for, what do you think is the classic triad of symptoms?
Episodic headache, sweating, palpitations. When medical professionals see these 3 simple alarm bells ringing together, it signals a massive malfunction in the adrenal glands. It literally means this tumor is dumping huge amounts of fight-or-flight hormones directly into the system.
Okay, so how do we track all this down? Let's crack open the expert's toolkit in Section 5, the Endocrine Toolkit, Diagnosing the Chaos.
These specific blood tests are the exact gauges doctors use to read the body's internal control panel. TSH is your best initial screening test for the thyroid, while checking the free T4 is what actually confirms the dysfunction. The A1C test? That's the absolute gold standard for diagnosing and monitoring diabetes over time. And if you suspect adrenal insufficiency, like Addison disease, checking the morning cortisol is your go-to screening tool. Now, what's really interesting here is the insider knowledge on medications. These aren't just everyday treatments. They come with very specific clinical caveats that experts memorize. Metformin is first line for type 2 diabetes, but you absolutely have to hold it for patients getting iodinated contrast or those with acute kidney injury. GLP-1 agonists are super famous right now for weight loss and cardiovascular benefits, but they do carry a risk of pancreatitis. SGLT2 inhibitors protect the heart and kidneys, but they can trigger a sneaky condition called euglycemic DKA, where blood sugar levels look relatively normal, but the patient is actually in a full-blown crisis. Oh, and levothyroxine for hypothyroidism? It absolutely must be taken on an empty stomach, otherwise it just won't absorb correctly.
For our final stretch, let's hit Section 6, Medical Traps and Secrets, Avoiding the Pitfalls.
Let's start this off with a high-stakes, life-or-death trivia question that totally separates the novices from the true experts. When you're treating a patient with that adrenaline-pumping tumor we talked about earlier, a suspected pheochromocytoma, what is the most common and frankly most dangerous medical trap?
You always start alpha blockade before beta blockade. Giving an alpha blocker first and a beta blocker second is completely critical. Starting a beta blocker before an alpha blockade is a classic medical board trap, and getting this sequence backward in real life is an incredibly dangerous mistake.
Here's another massive pitfall, confusing these 2 pituitary issues. Diabetes insipidus, or DI, is completely different from blood sugar diabetes. DI causes intense polyuria, meaning excessive urination, which leads to high sodium levels. The treatment for that is a medication called desmopressin. Conversely, SIADH causes the exact opposite. The body holds on to way too much water, causing confusion and dangerously low sodium. And the treatment here isn't a drug at all. It's strict fluid restriction and sometimes hypertonic saline. They sound super complicated, but understanding that contrast ensures you never mix them up.
Okay, we absolutely cannot skip this one. Never, ever abruptly stop chronic steroid therapy. See, when a patient has been on prolonged glucocorticoids, their adrenal glands basically go to sleep. So the crucial point here is that stopping abruptly can cause severe adrenal suppression. The master control board literally crashes. It's a huge board trap, and experts know you always have to carefully taper these medications to wake the adrenal glands back up safely.
As we bring this explainer home, I want to emphasize this golden rule straight from the source material. Treat the patient, not just the lab value. We've spent this entire time looking at TSH numbers, A1C percentages, and cortisol levels. And sure, the numbers on the control panel absolutely matter. There are guides, but the human being experiencing those symptoms matters far, far more. If the labs look perfectly fine, but the patient doesn't, the true expert keeps digging. So, we've officially decoded the master control room of the endocrine system. From the pancreas managing our fuel, to the thyroid setting our temperature, to the adrenal glands keeping us alive under extreme stress. It's just a brilliant, delicate machine. I'm going to leave you with this provocative thought. As you sit here right now, how well are your own body's microscopic chemical messengers balancing you? Thanks so much for exploring this amazing internal machinery with me. Keep that curiosity alive, and I'll see you next time.